Sorry, I'll click it here. I'm sorry. Yeah. So this is it again. I'm just showing the non-homogeneous opacity here. I can see a pneumothorax here. Maybe I'll say it's a tuberculosis. I don't think it'll be asked for the ICU exam, but I want to reiterate that there's a vascular area here with the collapsed lung. There is a pneumothorax here. This looks like a non-homogeneous opacity. Pulmonary still, I might definitely think about tuberculosis in this case. I don't know what case it was. Some X-ray has shared with me. Some kind of a cavity here. Consolidation looks like a tuberculosis to me here. That is fine. So there's a hyperinflated lung field. I told you. The costophrenic angle, the cardiophrenic angle, if you make a line and against the diaphragm is definitely less than 1 centimeter. It's a COPD X-ray. And this is a dextrocardia. This is a dextrocardia X-ray.
We'll just ask candidates to just describe one or two.
Please,
This one.
Yeah, please.
Somebody, please see if you can read the X-ray, please. We'll try 2 or 3 X-rays for the participant reading.
This left-sided pneumonectomy.
Sorry.
Okay, left-sided pneumonectomy it seems. Okay.
Yeah, difficult to say. See, pneumonectomy means say obviously history will be there. Then there will be a white hemithorax or opaque hemithorax. So then usually after we remove the lung, this area will be filled with serosanguinous fluid. Then there will be contraction will happen, Then the trachea will shift to the same side. That is going to happen. There will be evidence of volume. Yeah. So this is something is happening. Here there is a right upper collapse. That's what it is. So you see the horizontal fissure is like this. I hope you will be seeing what I'm seeing. This fissure has been pulled up. There's a concavity downwards. This is the right upper collapse. I can see some sort of sternal sutures. I can only guess that some kind of a aortic PAMT, maybe some kind of a aortic, some replacement has been done here. That's okay. This is just to identify that it's not going to be asked. Be aware of the thing. This you can see a lot of millet-sized shadows, 2 millimeter shadows. The commonest diagnosis of miliary TB, metastatic malignancy, sarcoidosis. This will be the millet shadows. You can see the the grain shadows or whatever you see in the X-ray. This X-ray I can see. I think there is a valve which has been replaced. I need some more thing. Maybe this is a mitral valve, I believe. PAMT. Maybe it's a mitral valve. So that you can see that nobody is going to fail you or whatever about based on that. So this is again, some kind of a kinging of the Swangans has happened. I think no, it's not kinging. It has just gone here. It has just come here. It has gone a little bit, protruding. Usually, should not cross the mediastinal the contour.
Yeah, it's gone too far, I guess. Into pulmonary sub-branches.
Yeah. So this is like a mediastinal mass. So basically, usually it's the lung mass means it will make a acute angle with this area. This making a kind of a. This is difficult to say. It's a mediastinal mass. I don't want to go to it. It can be very, very much debatable. Looks like a mediastinal mass to be the superior mediastinal mass. So this is again, it's a single chamber. This is not a dual chamber pacemaker. I cannot see, but I think it's only in the right ventricle. It's a single chamber pacemaker. It is not dual chamber. There is no 2 pacing wires are not there. I mean, again, it looks like some kind of a right endobronchial intubation to me because it's only discussion. I can see that, the tube appears to be going to the right side, but again, we need some more clarity on that. There's a pneumothorax. I will say from a pulmonology point of view, it's a hydropneumothorax. You can see the air fluid level here. There's a tension hydropneumothorax here. So why normally see if you say pneumothorax, that is more than acceptable. But if you ask me, there is an air fluid level here. You cannot have a straight line at the bottom. So there is a small tension hydropneumothorax is there. This area, some TB or something is there. The right hilum is up. So that's okay. This is just to show you some. My intention is just to show you some pictures. That's all. So here, what I can see is I'm not able to identify not much. I can see something here, the gallbladder area. I'm not very sure about it. Yeah. So this I can see. So this is a kind of a, I understand there is no calculi in the gallbladder. You can see there is an embolism. There is a peribladder. There is a collection is also there. Acalculous cholecystitis. Some kind of an infected gallbladder. Acalculous cholecystitis. Sometimes this can be a case scenario also once in a while, but this is not very commonly seen. Usually, acalculous cholecystitis, the background will be there. The patient is in the hospital. Patient is in the hospital for couple of little bit longer days. Treated with multiple antibiotics. Patient suddenly develops a fever. Nobody knows the cause of fever. You see the gallbladder, which is in a distender, but there is no stone there. Pericholecystitis collection is there. Patient is very sick. Means sometimes patient is too sick, then you can go for a bedside, percutaneous cholecystostomy. Then you can later on you can go for a cholecystectomy and all. But I just want to be just to prime you that this I didn't fully understand. I don't want to discuss. So again, I can see the splenic here, spleen here. There is some conduction happening here. So there is some kind of hemoperitoneum also, splenic conduction, splenic injury has happened. I can see there is a hemoperitoneum here, some contrast or something in the tummy. So there is a hemoperitoneum. Depending on that, if it's a trauma, I will say hemoperitoneum. Otherwise, I will call it as a ascites. And some kind of a contrast, some white thing I can see in the stomach. This is, some kind of a nodular shadows. Maybe you can say miliary. Some areas are confluent miliary shadows. This won't be asked for the exam. This is a classic, miliary tuberculosis. You can have, sarcoidosis. You can have, some kind of metastatic malignancy. This will be the pulmonary point of view. That is fine. Pulmonology. Yeah. So this is a very classic thing Dr. Justin was repeatedly mentioning. You can see the aorta here. This is SVC here. This is the descending aorta here. This is the main pulmonary artery. This is the right pulmonary artery, the left pulmonary artery. You can see the filled-in defect here. The right as well left pulmonary artery. There is a bilaterally extending the division. It's a saddle thrombus. So it's very clear. The answer is bilateral pulmonary embolism. You can see, as I told you, there is no doubt about that. This X-ray, I told there is something, the inguinal tear. You can see that the descending aorta. It's very classic. You can't miss it. And it's a very classic, EDH. I told with the midline shift here. Obviously, an arterial bleed. I told you many times. It doesn't cross the sutural lines. Bone is not broken here, but anyway, there's a lot of significant cerebral edema. You can see the significant cerebral edema has happened here. You can see the ventricles are even you cannot see that. This is a kind of a sort of subdural hematoma. It has crossed all the all the sutural line. There is a midline shift is happening. There is some kind of a hydrocephalus also I can see. And this is a classic, I told you, subarachnoid hemorrhage, which I showed you the previous thing. Nobody can forget that, because if it's come for case discussion means the entire thing will be lost. This again, you can see the sulcus. This is a subarachnoid hemorrhage. You can see the cross-shaped sort of thing. You can see that, the subarachnoid, you can see the hemorrhage here. You can't miss that. The previous picture was very classic. And again, you can see the contusions here. The frontal area, a lot of contusions are there. A little bit of an edema around. And I think that's it. So thank you very much. And I think Dr. Mahesh and Dr. Justin can add something. And if time is there, we can discuss something. Yes, Dr. Justin, Dr. Mahesh.
Thank you, Ajith. We're trying to see if Mahesh can put up sort of 3 or 4 images, and then we will try students to see if they can attempt reading few images. Now that they've had a good what we call a primer from chest X-rays to almost MRIs. So we will just give a trial of few images to see how much they have grasped for the evening.
Yeah. Mahesh?
Ajith, if you can stop sharing your screen. Then
Oh, sorry.
Mahesh
Oh, okay. Right. Yeah.
He will share it.
Yeah. Mahesh is around, no? Yeah. Sorry.
Yeah, I'm trying, sir. Just a second.
No problem. Thanks.
I think it's in a PDF format. So
Yes.
it's visible, right?
Yeah. Absolutely. And you probably can. Okay, it's a PDF format. Okay, you can expand as much as possible. Yeah, thanks.
Yeah. So
Visible, right, sir?
Yes.
So can anybody please based on that history and all that, can you please give it a go? Read the X-ray. Please, any of the participants. We'll try out few.
I'm able to see opacity in the right side, middle and the lower lobe, sir, and able to obfuscate minimal air bronchograms that can be seen. Most probably with the history, it can be a consolidation secondary to community acquired pneumonia.
So yeah, so we always describe the lung lesions as homogeneous or non-homogeneous, isn't it? So a lesion on the right hand side, a lot more homogeneous or non-homogeneous. Yeah, it is non-homogeneous. So involving mid and lower zones, and I think you commented the rest of the things like air bronchogram and all that, and consistent with consolidation or pneumonia. Yeah? Yeah. So we'll try that. So obviously this is the finding is, as you described, a good air bronchogram on a CT as well, and it also says the regions where it is involved. So that's just the confirmatory for the same patient. We'll do the next one.
Yes, sir.
Yeah.
So elderly male following aspiration with hypoxia and increased work of breathing. Antibiotics, oxygen therapy. Post that he improves. Next morning he has acute shortness of breath and chest X-ray shows this.
Based on our the chat, what has happened with somebody say what
Right
was
hemithorax, the right opaque.
it's almost like a
hemithorax.
homogeneous, lot more homogeneous than the previous image.
Hmm.
So the minute when it is homogeneous, we are looking at either a water or a lack of air completely, which is more like a collapse. So somebody aspirated.
The heart has shifted to the left side. The heart of the entire mid-diastole had gone to the right side. So that means the evidence of volume loss is on the left side. You cannot see hardly in the lung here. You can see that trachea is the same side. So evidence of this has shifted to the left side. There is a left side collapse. There's only 3 diagnoses we told. One is a collapse, one is a fibrosis, one is a pleural thickening. But obviously collapse is the first diagnosis. Fibrosis will not happen overnight, just like Dr. Mahesh is telling. Next day, the patient is found like this. This is a collapse. There's a right lung collapse. Mahesh, you want to add something?
No, sir. No, sir.
Yeah.
Likely to be secretions.
Secretions.
We'll ask them to answer, sir. I think let them answer.
Yes. I can't hear anything them telling here. Anyway, sorry.
They'll answer, sir. Let them answer.
Yeah, please. Sorry for that.
Yeah. Middle-aged female with the lot of short forms. I think following mastectomy for breast cancer, now sudden onset of left-sided chest pain and shortness of breath. Obviously, there is some history of long air travel with the left lower limb swelling, and she is hypoxic. Can anybody answer this? Sir has shown these slides.
So there is a wedge-shaped
shadow on left side.
Yeah, Kiran, you can answer loudly. Yeah.
Wedge-shaped opacity on the left side. So looking at the history, looks like pulmonary embolism in this case.
Yeah. And what is this sign called?
Hampton's.
Is it? Or something else?
Western mark, no, not Western.
There is a relative avascularity is called Western mark. The relative avascularity is called Western mark. Am I right? Yes.
Yes, sir. Yes.
Yes.
And exam, they may ask you, how do you manage the patient also? Be prepared for that. It won't be only identification. They may ask you, how are you going to manage? Can any one of you answer that? How are you going to manage this patient?
Depends on his hemodynamics.
Excellent. So patient at this point of time seemed to be only hypoxic. Blood pressure seemed to be reasonably normal. So next.
We'll send the cardiac biomarkers.
Initially, patient's airway has to be managed since patient is hypoxic. So we have to either assist his airway with either oxygen or NIV to reduce his work of breathing. Then we'll get if there are no contraindications for a CTPA, we can get a CTPA done. Or if the patient cannot be moved or CTPA is contraindicated, then we can have an echo with the cardiac biomarkers done. And based on that, we can classify whether it is a massive pulmonary embolism or a intermediate low risk pulmonary intermediate risk pulmonary embolism or a low risk pulmonary embolism, and then go with managing that.
Yeah. So thrombolysis or anticoagulation based on what is the risk. Okay, fine. Okay. Any one of you can read this?
CT window showing bilateral filling defects in the right and left pulmonary artery as well as in the midline, suggestive of saddle pulmonary thromboembolism.
Yeah, good.
Excellent. Yeah. So,
Somebody else can try. Yeah. Middle-aged male, alcoholic, here with the acute worsening of shortness of breath. What to do next?
just a brief description of the X-ray. So, it looks a lot more white than expected, and like Dr. Ajith kept saying, the mediastinum hasn't at least moved to the same side. So it's a homogeneous opacification of the right pneumothorax, with the trachea probably still in the midline or may even actually be pushed to the left side.
Left side.
So that means that there is something that is like an accumulated rather than a loss of volume. So it is more likely to be, in this case, acute setting means that either, like somebody said, Kushbu has said, massive pleural effusion, or with the infection plus effusion, either one. Yeah. So when you approach it like that, then it would makes it easier. So somebody give it a go with this one, the next patient. So look at the X-ray and describe it, and then we can come to the diagnosis easily. Yeah. Shashidhar, go ahead. You come with a diagnosis, but you have to describe the findings to say that consistent with pulmonary, like that. Yeah. So what are all the things are there that is consistent with pulmonary?
Bilateral pleural effusion.
Okay.
Because the patient is congestive heart failure, I mean, a known case of CAD, sir. So it can be orthopnea PND. So it can be a second congestive heart failure, bilateral pleural effusion.
Bilateral pleural effusion. Okay.
Yeah, I mean, there are other things also. If you see
Pericardial congestion along with bilateral pleural effusion.
cephalization of veins also you can see.
Pulmonary hypertension.
Sure. Okay. Yes, I think we are fed up of this X-ray. I think I'll change.
No, again, Maisha, again,
Yes,
you are expected to see 1/3 of the heart here.
Yes.
So it's not in a really 1/3. So naturally, it's a total collapse on the left side. Yeah.
Yes. Yes.
Ajith is more interested in answering the questions. He's keen to take IDCCM again.
No.
So, I mean, there are various presentations of pleural effusions here. Can one of you describe? What is this first image?
So that looks like empyemothorax, sir, because it's more like organized.
Okay, you can mention it as more of loculated effusion. Okay.
Yeah.
Could be embolema.
Then down one is bilateral pleural effusion.
Yeah. And what are the causes?
So,
Congestive cardiac failure, renal failure,
Cirrhosis.
Then
hepatic
liver
failure.
failure. Yeah. Okay. And this one?
Unilateral pleural effusion causing collapse of the lung with a small piece of lung.
Okay. This is on right side or left side?
left side loculated pleural effusion, sir.
Locculated, we are not sure.
Many fibrin strands can be seen.
Where you can see that? I can't see that. Okay.
Oh, that's okay. Yeah, but
Yeah,
I mean,
no
fairly uniform image, so that's okay.
Yeah.
All right. So, how about this one?
Hydropneumothorax.
No, read the history. There is some history also.
Yeah, you're right. You're right. Yeah.
Hemopneumothorax.
Pneumothorax, yes. Air fluid level. The previous X-ray, it is not pneumothorax. If you say it's a tension hydropneumothorax, I told you there is an air fluid level is here. Yeah. I mean, in the previous X-ray on the left side, one of the X-ray which I had seen. Basic concept, that's all. Yeah. Yeah.
Carefully see whether there are any associated rib fractures. Okay. Not very obvious, but we'll have to look into.
So somebody describe this X-ray for me, please. This is quite common in ICU for us.
There is bilateral non-homogeneous opacity.
Excellent, super. Consistent with
ARDS, acute
ARDS, yeah.
respiratory distress.
Or yeah.
Or it can be a patient with pleural effusion taking the flat.
Yeah, excellent. That's true. So it could be a simple cardiogenic pulmonary edema as well, isn't it? You don't know otherwise. Yeah.
Yes, it is non-homogeneous.
Yeah. So you say that bilateral, non-homogeneous, symmetric picture at this point of time. So the features constant with pulmonary edema, either cardiogenic or non-cardiogenic. Right.
It's a rotated film. Otherwise, other differential diagnoses like RHD, mitral stenosis, these things you need to keep in mind. But here you can't comment because it's rotated.
Yeah.
Anybody wants to comment on this?
Yeah. Somebody put the money into the pot. So exactly.
Money in the bag.
Yeah, Rajavardhan took the money. Like I said, I think we need to make sure that we describe the main pathology there. So obviously it's a cardiomegaly, a globular in shape, and this is more consistent with pericardial effusion than pure any other cardiomegalies, like whether restrictive or constrictive or dilated cardiomyopathies will not be having heart of this size. It has to be pericardial pathology. So that's what it is. And then you can always debate the causes, whether it is a tubercular or cardiac failure itself, or a renal failure or uremic. So you can always debate that malignancy otherwise. So, but at the end of the day, we just wanted you to describe that first. So it's a globular heart or cardiomegaly, simple hypothyroidism, somebody's another cause. Yeah, go ahead. Next one.
So more than 50% of the hemithorax, yeah.
More than.
That's it, yeah. It's a pericardial effusion.
You said
pericardial effusion, yeah. 50, no, this is 50% in adults. In children, no, 50. In children, the heart will be a little bit high, so it should be more than 55%.
Okay.
Adult mean it is 50%, yeah. 60%, my apology, yeah. So more than 50%, you see the largest from the mid vertebral point. You see on both sides, whichever is the largest, the distance, on whichever side of the heart you take and you add. More than 50% adult is cardiomegaly, more than 55%, if I'm not mistaken. In children, it's cardiomegaly.
Anyone wants to comment on this?
It's pericardial and pleural effusion both.
Yeah.
Excellent.
Yeah.
Excellent. Very good. Yeah. Okay, this one.
Pneumothorax.
Sorry? Left?
Left-sided tension pneumothorax.
Yes, it is not a pneumothorax. It is not at all a pneumothorax. It's a tension pneumothorax because the BP is also on the lower side. And the heart also shifted to the opposite side, if at all. So 100% is a tension pneumothorax. It's not a pneumothorax at all. It's a tension pneumothorax.
So what will you do? What will you do? What is the immediate management?
Place a ICD or a
Needle thoracostomy.
Okay. You want to put ICD or needle thoracostomy?
Needle thoracostomy immediately.
Okay, where will you put the needle?
Fifth intercostal space, sir. Axillary, mid-axillary.
Excellent. So I think that's a change, I think, compared to the previous safety triangle. Yeah. So, yeah. Somebody can read this one, yeah? Pancreatitis patient. Patient is hypoxic, so there could be many reasons. So anybody see all the, so maybe just read everything in this patient. So maybe approach from the top to bottom. So all the gadgets, whatever.
The nasogastric tube is misplaced. It's in the.
Okay, nasogastric tube. What are the other hardware in this patient? We'll just take stock of. Somebody sort of thought that it was a TPI lead, but
There's a central line.
there's a central line. So left internal jugular central line, isn't it? It's crossing across. Is that a right one? Right one, yeah.
right.
Okay, yeah. What are the line coming from the left? Those are all. There's another one coming from the left, I think. Yeah. Is there endotracheal tube? There's an endotracheal tube. Chest leads. Yeah. Yeah. So the left side looks like hyperlucent. For somebody who's hypoxic, that seems to be quite hyperlucent, isn't it? Yeah.
Yeah.
And what else is there on the left side?
The RT is probably in the pleura.
RT is in the pleura.
Looks like a thinner tube, no? More like a nasojejunal tube. No, it's okay. There is a tube is there, I know. Looks like a thinner, doesn't look like a classic Riles tube. Anyway, that's fine.
That's true.
Gas under the diaphragm.
Gas under this one, is it?
That's a gastric.
That's a normal.
No.
Left
Gas is above,
Left
gas
side
is above the diaphragm.
status
Yeah.
post.
That is Pandey careful.
And also direct
Yeah, pneumothorax. That's it.
So post line, I
Yeah.
think. Yeah,
Same.
that's good. That's good. Yeah. So
right pneumothorax.
Yeah.
next one, I think it's the same
Yeah.
picture. I think.
Yeah, yeah, sure.
That's a tension pneumothorax, yeah.
Okay.
This one. This is nice. You'll get it in the exam.
Bat wings sign.
Read the history, okay? It's given
We'll read the
32-year-old.
X-ray. So we'll just read it
Charlie.
and then
Charlie.
yeah. So we will say that bilateral, non-homogeneous opacities, symmetric opacities. Yeah.
Following blood transfusion, isn't it?
Yeah. Given the history, most likely to be Charlie.
Taco is also.
Taco, Charlie.
Yeah, I think. Yeah.
Yeah. That's it.
Intra-aortic balloon.
Yeah.
So generally we would want it around where? The tip of the catheter. Where do you want it to be?
Descending aorta.
Ascending, yeah, no, we want it below the subclavian origin, isn't it? So ideally fourth intercostal space. Yeah. Yeah. Below subclavian, yes, maybe.
Single chamber, please.
It's already answers are written.
This is single chamber, no?
Single
Yeah,
chamber.
Yeah,
So
I
this
see
is
it, but it's gone through the wrong channel, wrong pathway than expected.
Yes, yes.
Yes, that's good. Yeah. All right, so
Yeah,
maybe
sir, I think-
next one. I think if there is any one pathology, maybe is there a non-chest X-ray pathology? Is there?
I'll just see. Sir. Yeah.
Yeah.
Aortic
Aortic
dissection.
Ascending aorta.
Section.
So they may ask you which one is false lumen, which one is true lumen.
Okay.
Right
And then
side is the true lumen.
Large
And then-
lumen is a false lumen.
Okay. Yeah.
what's the types of dissection for us? Types of dissection or classification of dissection. Just think about it. Yeah. That's all right. So multiple. Excellent. Yeah. So
Yeah.
multiple pillars. Yeah. For surgeons, they will ask you how many numbers, but 3 to 5, more than 3 to 5 is obstruction. Up to 3 is normal. Yeah. Very good. Lot of
Left
medicine.
renal calculus.
Yes, excellent. That's good. That's good. That's good. That's good. Excellent spot. And this is something that you may get in the exam. Excellent, excellent. So this is something very common for us, and we always do the CTs or ultrasounds for all patients who come with a urosepsis to look for what we call as a surgically manageable problem, like urosepsis, bad pyelonephritis or a hydronephrosis. So that's something to just remember. Other than pancreatitis, hydronephrosis are the from abdominal point of view, and the trauma abdomen, like liver laceration, are probably the three common or pneumo air in the liver, portal air for ischemic hepatitis, so or ischemic colitis. So one of these 4 are commonest CT scans that are shown in the exam. So think about those things. Yeah.
Large calculus in the gallbladder.
pancreatitis.
Excellent. Pancreatitis. Calculus. Yeah. Yeah.
Right, emphysematous pyelonephritis.
Emphysematous
Yeah,
pyelonephritis.
pyelonephritis. Excellent. Very good. Yeah.
Liver laceration.
Liver laceration. So it is a high grade liver laceration. You may not necessarily need to say numbers, but anything that goes closer to the hilum or extending everywhere, or has a large blood around into the capsule, we always say that high grade liver laceration. So that's a good way to start. Even if you don't say the grading, it's okay, but mostly that's what we want to know.
Calculus cholecystitis.
Yeah, so there is some calculus is there, and so it is probably a calculus cholecystitis. That's probably what it is. Yeah.
Intraventricular bleed with midline shift.
Intraventricular, it is what is the source for it most likely?
Hypertensive bleed.
Yeah, that is because where?
Ventricular.
So they may ask you what are the common sites of hypertensive bleed.
Basal
ganglia.
So a basal ganglia bleed Now it is not only stayed there, but also into the ventricles, so intraventricular extension. And what else it has caused? Just caused midline shift and also certain amount of early hydrocephalus. Yeah, and focal edema or diffuse edema, whichever. Yeah. So when you say all those things, then it makes us a fulfilling answer, and then the examiner can quickly go ahead and it can do what next. Excellent, Rajkan. Yeah. So now we will try to see either you can use the index problem and then all the other problems, or you can go systematically.
Extradural.
One of you try. Okay. So no, this will be said right-sided extradural hematoma. Yeah. With a significant mass effect, isn't it? Yeah, loss of sulci gyri, diffuse on both sides, as a matter of fact. Yeah. And the mass effect is pronounced significantly on the same side. Yeah.
No, not crossing the sutural line. There is an associated bone fracture also is there. There is an arterial bleed. All these are hitting.
So when you say that, then it becomes a holistic answer. So then quickly you go to the next slide.
Yes, any intracerebral event mean you should always should not forget about mentioning about the midline shift.
Yeah.
STH.
Yeah.
Right STH.
Right side of
Right-sided
with midline shift.
Midline shift with significantly at this point of time, SDH mass effect, which is clearly it's more than a centimeter, isn't it? More than a centimeter.
Yeah, if the SDH is the thickness is more than 10 millimeter, or the shift is midline shift is more than 5 millimeters, it is indication for evacuation.
Yeah.
So midline shift more than 5 millimeters is indication for evacuation. Yes.
You have to mention acute SDH. That is also important.
Yes.
Acute, yeah. Very good, very good. Thanks for that.
Right-sided acute and chronic SDH. With
Excellent. Excellent. Very good.
I may say that this will be a subacute also. The color is sort of, it's not purely black, maybe subjective. Anyway, maybe. Yeah, it's acute, there is no doubt. Acute or chronic, acute or subacute. I don't know, maybe. Yeah. The color is not really dark. Yeah.
Left-sided MCA infarct.
Yeah. Excellent. Yeah. So that's okay. Next.
Yes.
That's it.
Yeah.
You are
Polycystic kidney disease.
This patient came with some of the headache. Can you correlate that?
Aneurysmal bleed.
Polycystic kidney disease.
Aneurysmal hemorrhage.
Yeah.
Yeah. Excellent, excellent. One last one, I think maybe. Yeah, one last one. Yeah.
Polycystitis with
so there is a, yeah. Polycystic edema significant, and then there is
Artifact.
gallstone.
The caustic shadow.
It is causing some kind of artifact here, gallstones. Yeah.
Yeah, this negative shadow because of the stone.
Yeah.
Yeah.
This is the
Pleural effusion. Pleural effusion.
Collapse.
Pleural effusion.
B lines.
No, they are horizontal lines. Yeah, lines. Reverberation artifacts.
These are
B lines. B lines.
Diffuse.
Yeah, done. I think.
That's okay. Yeah, we'll probably end there for a radiology session, and I thank Dr. Mahesha for the assisted and moderating the session, and Dr. Ajith Kumar from Pastor Whitefield for taking time and teaching us basics of radiology towards the exam, and hopefully at least one or two will be helpful for your exam. And one comment about tomorrow is that because there is an orientation session by IDCCM for all the exam going people, and we were going to do the airway and drugs tomorrow, so we will do the session a bit early, 5:30 to 7, not 7 to 8:30. So If it is uncomfortable or inconvenient for some people, I'm sorry, but IDCCM exam session gets a priority. So whoever can join, please do so. And the day after also, we will have an early session, which is an ACLS, 5:30 to 7 again. So 2 consecutive days of 5:30 to 7. Yeah. So if you have any questions, please don't hesitate to reach out to any one of us. We're happy to clarify queries or anything to do specifically, any specific problem relating to any of these things. Yeah.